Okay, so the patient was 61-year-old, presented with incidental findings seen on the ultrasound, so the clinician referred him for CT with contrast.
Recording in progress.
دكتورة ممكن شوية على كيف تتكلمين؟
Okay.
هذه نيتف.
Okay. The contrast.
incidental finding
Incidental.
كانت symptom. دكتورة بس بورتال مسوية ما مسوي لها دايناميك؟
لا.
دكتورة طلعي لي كورونا بلا زحمة معليش.
انت شفتي بهذا
المشكلة
أستاذك في الديليشن بالريلاتيف للستومك. يعني بس أريد أتأكد إنه بيابارت من الستومك عمي. ماشي عمي أستاذ.
هذا الكور.
أي هذا هنا. multi sequences CT scan native and portal face and dynamic portal face.
multi sequence.
multi sequence multiplanar CT scan.
multi sequence multiplanar.
multi slices CT scan.
وهمون مالتي بلانر مالتي سيكونس هذا الMRI يعني على مود
CT scan. The lesser curvature within the enteral part of the stomach. This lesion is looked to be يعني mild necrotic change within the lesion. يعني mild heterogeneous signal intensity, mild enhancement post contrast study, not cause يعني فد luminal narrowing or stenosis within the stomach. The surrounding fat look to be يعني ما عندنا surrounding be clear. No obvious lymph node enlargement surrounding the stomach. And يعني ما عندي فد another lesions liver look to be أعتقد normal. والله حركي لي شوية على الليفر دكتورة رغد.
So features of
يعني هي feature يعني most likely فكرت أنا بالجست gastric gist gastrointestinal stromal tumor بس ممكن أخلي differential diagnosis of مثلا.
احنا قبل ما ننطي diagnosis
benign lesion عمي. يعني benign lesion مو malignant أو aggressive
بالضبط
lesion.
يعني قبل ما هذه يعني واحد يروح للهيستوباث diagnosis ينطي فد انه الفيتشرز اللي انت عدتيها طبعا عاشتي انه ذكرتي البوزيتيف والنيجاتيف ماكو lymph node ماكو invasion adjacent structure. هاي الفيتشرز كلها consistent with goes with a benign lesion. خلينا البوسيبيليتيز بعدين مع البناين lesion of the gastric wall lesion اللي هي مثلا جيست. بعد اكو other differential diagnosis.
ممكن فكرت عن باليوما بس هي rare بالستومك يعني مو كمان
لا يوما excellent. وين اكثر شيء كمان؟
هي بالإزوفيغس. mostly
صح.
calcified lesion
صحيح.
أو اليوميوساركوما اللي هي المالجننت بارت من اليوميوما، هذه هم يعني رير أكثر من اليوميوما. أو نفكر بالكارسينويد، هم هو مو تيبيكال ولا الكومن سايت اللي واحتاج دايناميك حتى أقول إنه هذا كارسينويد، لأنه نعرفه هايبر فاسكولار وانهاسمنت مالته أرتريال فيس. يعني
وعادة سمول سايز ما يجي
تكون
بهالكبر.
سمول سايز، يعني والبرزنتيشن مالته مو اسيمتوماتيك لأنه هو نيورو اندوكراين تيومر، ويعني يصير سكريشن اوف ميني هرمونال انزيمز اللي تسوي البيشنت سيمتوم ديتكشن يصير ايرلي، يعني مو يكون اسيمتوماتيك. فأما إحنا إذا شفنا حاليا ليجن حتى لو تشانجز، فإحنا يعني important إنه ندور على ميتاستاسيس، هو حتى even just or حتى اليوم ما يوم ممكن تسوي ميتاستاسيس.
نسبة
يعني
الجست مالجننت
أمي أعتقد يمكن 10%، ما أذكر بالضبط.
اوكي، شكرا دكتورة رشا، عاشتي.
أهلاً بك.
دكتورة اسماء خزعل.
نعم أستاذ.
صباح الخير.
صباح الخير رقم أستاذ.
Your opinion بابا.
نعم أستاذ، وهذا أهمه لأنه هو well defined soft tissue mass. look في أنه يعني benign lesion, not sigmoid obstruction, not يعني no periaortic أو periportal lymph node, no liver metastasis. يعني فنخلي كما قالت رشا زميلة رشا إنه نخلي benign lesion. نخلي أول شيء هو إحنا قلنا just أول differential diagnosis اللي هو most common بالستومك. كارسينويد يعني كما قال ما نخلي كارسينويد لأنه هو هايبر فاسكولار يجي أكثر شيء بالميزنتري سمول بول ميزنتري. نعم أستاذ.
أسماء، شنو الفيتشرز اللي goes with just in this lesion؟
أول شيء عنده فيتك ليجن. ثاني شيء اكو بيه شويه سنترال بروسيس، يعني مو هواي يعني. ثاني شيء هو يعني well defined lesion.
والبرزنتيشن
البرزنتيشن هو يعني اكثر شيء accidental finding، لانه هو مو لارج على مود نسوي obstruction او نسوي فد اي. نعم استاذ.
واي من الجست ليشن هو انسيدنتال، احنا نلقاها
انسيدنتال. نعم استاذ. نعم استاذ. انسيدنتال فايندينج.
اسماء شو يسوي له هذا؟
عم هو يسوي له سيرجري. يعني هو يسوي له سيرجري عم، لانه هو 50% يجي يعني ميتاستاسيس مرات يجي، فهم يسوونه سيرجري.
50% is too much.
اي هم عمو هيك قريت بال
50%
بعد 50% قريت.
من يعرف ايش قد نسبة الجست الميتاستاسايز او مالجننت؟
10%.
يعني اللي اعرفه يعني 10، هو مو
اي يعني 10.
عمو بال انا ما ادري شو
راديوبيديا انت قريتي؟
راديوبيديا يا عمو. يا عمو يسال راديوبيديا ميتاستاسيس.
على كل نرجعوا لها تاكدوا منها ايش قد نسبة الجست اللي مالجننت او ميتاستاسايز. one have to look for. اوكي، شكرا اسماء الشديد. نرجع على دكتورة رغد سعدون. احكي لنا بنتي على الكيس واذا مسوية توك حتى
إن شاء الله. الكيس 61-year-old male present يعني had an incidental finding on ultrasound as mentioned, there is mass, epigastric mass related to the head of the pancreas. So يعني contrast CT was done for him, which revealed evidence of endophytic, well-defined heterogeneous mass seen in the antrum of the stomach with minimal enhancement post-contrast. يعني smooth out with a smooth outline. Fortunately, there is no architectural distortion, no vascular encasement, no adjacent organ invading or mesenteric or omental. The picture strongly يعني suggesting of the gist. post-op يعني excisional biopsy and immune staining both reveal the diagnosis of benign GIST. أنا سويت له ultrasound يعني
خلينا نشوف. هي عايشة تيدي.
هذه كانت يعني well defined hypoechoic with cystic change vascular bicolor Doppler يعني شفناها تقريبا adjacent to the border of the left liver lobe. وهذا مالتين فيديو يعني I start at the level of the يعني pancreas and go up. This is the mass.
يعني هم من يكتبون تعرفين من يكتبون بنكرياتيك هيد تيومر أو فشي يعني هو difficult يعني بصراحة. وهذا يعني المفروض مثلا يخلي البيشنت يشرب مي ويسوي extension fluid filled stomach على مود يتحقق منه، لأنه هو السايت مالته يعني بالابيجاستريك ريجن.
بالابيجاستريك تمام.
ما يخطر على بال الواحد. اوكي عايشة تيدي. اذا هاي نروح على التوك رغد.
اوكي هسه. I'll talk about neoplasm of the stomach. This is a picture of our case. We have benign tumor and malignant tumor in the gastric. Usually histologically they divided into epithelial, mesenchymal, and associated with other. This benign tumor and malignant tumor mostly or most commonly is a carcinoma presented about 90 to 95%, lymphoma and carcinoid about 3 to 4%, and malignant spindle cell or what we call mesenchymal tumor represent about 2%. I will talk about the gastrointestinal stromal tumor as it's related to our case. Then I talk briefly about other benign and malignant tumor as a differential diagnosis. Mesenchymal tumor is a rare, but the most common entity of which is the GIST. Previously, they call it as leiomyoma, leiomyosarcoma, or leiomyoblastoma, but this is no longer used as it's typically submucosal tumor, and they believe it's arises from the interstitial cell of Kegel. This is cell present in the submucosal layer of the gastrointestinal tract, and also they call it the pacemaker, which is responsible for the motility of the gastrointestinal tract wall. And just rarely seen before under the age of 14, gastric GIST usually presented smaller and less aggressive than other GIT GIST. Clinical presentation variable according to the location and biological behavior. Many tumors are incidentally identified. Some tumors are aggressive, so presented after metastasis. Larger tumor usually ulcerate, and when ulcerate presented with hemorrhage. About 50% of cases presented with ulceration presented with hemorrhage. And as it's gastric, so the patient presented with melena usually. Location seen anywhere in the gastrointestinal tract, but most commonly in the stomach, about 70%. 20 to 25% seen in the mid to the distal part of the small intestine. 7% seen in the anorectum. Other sites regarded as rare sites. To differentiate malignant from benign GIST, as we have benign and malignant entity in the GIST, so difficult radiologically. The diagnosis depend on the histopathological analysis, but we have many or some criteria that suggest a malignancy when we have exogastric growth of mass that diameter more than 5 cm, which have central necrosis or extension to other organs. Usually the GIST presented as well-defined soft tissue density mass arising exophytic or endophytic from the hollow viscous, mostly from the stomach. On the CT, it appears as a soft tissue density, and if the tumor is sizable or large tumor and have a central area or central necrosis, so the central area appear lower density in the CT. Enhancement, if it's small, so it's appear homogeneous enhancing and usually hypervascular and sometimes hypovascular. But if we have a central necrosis, typically presented with peripheral enhancement. Calcification is rare, and lymphadenopathy enlargement is not a feature of GIST. This is CT axial CT of patient show exophytic enhancing soft tissue mass lesion seen incidentally and the right curvature of the stomach, which diagnosed as a benign GIST. This is axial CT of 45 years old female. There is a large lobulated heterogeneously enhancing mass with area of necrosis. It has both intraluminal and exophytic component, and the liver show multiple iso to hypodense lesion with variable enhancement. So the case diagnosed as malignant GIST with metastasis to the liver. On MRI, presence of necrosis, hemorrhage, cystic change give us a variable appearance. So, but mostly it's appear as low signal intensity on T1, high signal intensity on T2 with peripheral enhancement in large tumor. This is an axial enhanced MRI of 54 years old man, show large well-defined mass with a predominant exophytic component arising from the greater curvature. There is unevenly enhancement peripherally. The case diagnosed as malignant gastric GIST. Radiological reports should include the following items: size of the mass, extension to the surrounding organs involving or encasement of the surrounding vessel. If there is lymph node enlargement should be mentioned, and this is raise the possibility of risk of gastric adenocarcinoma or lymphoma rather than GIST. Treatment and prognosis depend on the size, and if we have resectable or small size tumor, so managed surgically, then follow up with adjuvant chemotherapy. But in larger tumor or tumor presented with encasement of vessel or invading of adjacent vessel, started with a new adjuvant therapy. Differential diagnosis, we have been benign and malignant entity of GIST. Also, we have a differential diagnosis, benign and malignant. Most commonly, whole gastric adenocarcinoma. It's rarely seen before 40 years of age and has a relationship with the H. pylori infection. It is most common gastric malignancy, as I mentioned, representing over 95% of malignant tumor of the stomach. It's presented 30% in each of antrum, body, fundus, or cardiac region, but 10% is presented as diffusely infiltrating the entire stomach. A favored location of the GIST is lesser curvature of the antropyloric region. Gastric adenocarcinoma can manifest on CT as with annular constricting type or with shouldering edge, as we saw here, this shouldering edge. This is usually presented with gastric outlet obstruction. Also, they may be presented as irregular or polypoidal fungating mass lesion. The third presentation is diffuse mural thickening and usually associated with reduced gastric lumen. This is called lentis plastica and should differentiate it from lymphoma, as it's presented as diffuse wall thickening. Separate of gastric cancer. Usually we have the direct separate to the adjacent organ, lymphatic separate to the regional lymph node, but what is important here is separate to the left supraclavicular lymph node, what we call virtue node, and by blood metastasis, usually metastasize to the liver, followed by lung and bone. Transperitoneal separate is common anywhere in peritoneal cavity, and if reached to the ovaries, called Krickenberg tumor, or to the umbilicus, call it Sister Joseph nodule. Gastric lymphoma. Typically, appearance of gastric lymphoma is segmental or diffusely markedly thickened gastric wall with no definite lumen encouragement or obstruction. And this is should differentiate from diffuse adenocarcinoma, which is presented with diffuse wall thickening and luminal narrowing. Also, homogeneous enhancement of the wall and preserved of epigastric fatty plan help differentiate it from gastric adenocarcinoma. Lymphoma has a predilection for transbiloric separate for the duodenum, and usually presented with adenopathy below the level of the renal hilum, also favor lymphoma rather than adenocarcinoma. Metastasis to the stomach is uncommon and occur through hematogenous separate from melanoma, breast, lung, and ovarian cancer. This is case of 45 years old male with contrast enhanced CT show multiple smooth submucosal masses, hypodense center mimicking the bullseye appearance. This patient has a history of melanoma, superficial melanoma, and diagnosis was a metastasis to the stomach. Benign differential diagnosis, we have gastric lipoma. Usually this is old, regarded as differential diagnosis in barium study or endoscopic ultrasound. But on CT and MRI, the lipoma has its own characteristic signal intensity on MRI and fat density on CT. So it's not longer on the CT and MRI as a differential diagnosis for GIST. Gastric leiomyoma, usually seen in the esophagus and less likely to seen in the other gastrointestinal tract parts like stomach. But when presented on the stomach, usually seen in the gastric cardia. Usually it's homogeneous with low attenuation masses. One of the differential diagnoses of gastric masses are benign gastric masses in neuronal, like schwannoma or glomus tumor. This is axial CT image of gastric schwannoma presented as homogeneous solid mass. Gastric polyp, we have hyperplastic polyp, which represent about 80 to 85%, fundic gland polyp, and adenomatous polyp. These usually appear as a sessile or small pedunculated lesion, often multiple, and large polyp are very rare to present. The risk of carcinoma is moderate in adenomatous polyp and slight in hyperplastic polyp, and usually null in fundic gland polyps. This is a 16-year-old boy with Peutz-Jeghers syndrome. This abdominal axial contrast enhanced CT reveal multiple clusters, sessile homogeneous enhancing polyp. And if we see here in this picture, there is in the fundic picture, there is an interception, small intestine interception, and the leading point is the polyp. This is a 28-year-old man with familial polyposis, axial contrast enhanced CT of the abdomen reveal innumerable sessile and pedunculated polyps seen in the stomach, distributed diffusely, and the diagnosis was adenomatous gastric polyp. Thank you.
عشتي دكتورة رغد سعدون بس ذكرتي لنا ايش قد مالكنا